Welcome to Mastering Section E, Behavior on the MDS Assessment. In this video, we'll help you identify the various components of Section E, understand the coding instructions, accurately perform the steps for assessment, discover coding tips directly from the RAI, and recognize the impact of Section E on resident outcomes and developing the resident's plan of care. The intent of this section is to identify behavioral symptoms in the last 7 days that may cause distress to the resident, or may be distressing or disruptive to facility residents, staff members, or the care environment. These behaviors may place the resident at risk for injury, isolation, or inactivity, and may also indicate unrecognized needs, preferences, or illness. Here our section begins with Item E0100, Potential Indicators of Psychosis, where we will be coding any of the following behaviors observed or expressed during the 7-day look-back period. Hallucinations, the perception of the presence of something that is not actually there. This includes auditory, visual, smells, tastes, or touch. And delusions, a fixed, false belief not shared by others that the resident holds even in the face of evidence to the contrary. To assess for this item, we'll begin by reviewing the resident's medical record, interviewing staff members and others who have had the opportunity to observe the resident in a variety of situations, and by observing the resident during conversations and the structured interviews in other assessment sections, and listen for statements indicating an experience of hallucinations or the expression of false beliefs. If false beliefs or delusions were noted, but plausible, try to verify the facts to determine whether there is reason to believe that it could have happened or whether it is likely that the belief is false. Our next step will be to determine whether or not the delusion is considered fixed, and therefore appropriate for coding. In order to do this, an attempt to clarify any potential false beliefs should be performed to see if it can be readily corrected by a simple explanation of verifiable facts, such as a reminder, reorientation, or demonstration of evidence to the contrary. Do not, however, challenge the resident. A resident's response to the potential alternative explanation is often helpful in determining whether the false belief is held strongly enough to be considered fixed. Following will be Item E0200, Behavioral Symptoms, where we will be noting the presence and frequency of behavioral symptoms. Our assessment of this item will include reviewing the medical record, interviewing staff or others that had close interactions with the resident, and observing the resident in a variety of situations during the 7-day look-back period. Code 0 if the behavior was not exhibited. Code 1 if behavior of this type occurred 1 to 3 days. Code 2 if the behavior of this type occurred 4 to 6 days, but less than daily. Or Code 3 if behavior of this type occurred daily, regardless of the number or severity of episodes that occur on any of those days. This next item, E0300, will simply summarize whether any behavioral symptoms were coded on the last 3 items, E200A through C. How we answer this question will determine if additional items E0500, Impact on Resident, and E0600, Impact on Others, will be completed. If you answered 0 for no to all 3 above items, code 0 and skip to rejection of care. If behavioral symptoms were present, code 1 for yes, and proceed to the following items which will be used to understand its impact on the resident or others. Items E0600A through C will provide a space to review whether the identified behaviors place the resident at significant risk of physical illness or injury, interfered with the resident's care, or significantly interfered with the resident's participation in activities or social interactions. To assess this domain, consider the previous review of the medical record, staff interviews across all shifts and disciplines, interviews with others who had close interactions with the resident, and previous observations of the behaviors identified in E0200 for the 7-day look-back period. Here we will code based on whether the risk for physical injury or illness is known to occur commonly under similar circumstances. If the impact of the resident's behavior is impeding the delivery of care to such an extent that necessary or essential care cannot be received safely, completely, or in a timely way without more than a minimal accommodation. Or if the impact of the resident's behavior is limiting or keeping the resident from engaging in solitary activities or hobbies, joining groups, or attending programmed activities, or having positive social encounters with visitors, other residents, or staff. Similarly, E0600, Impact on Others will provide us with the opportunity to identify if the resident's behaviors have placed others at significant risk of physical illness or injury, intruded on their privacy or activities, or interfered with their care or living environments. Consider the previous review of the clinical record, staff interviews across all shifts and disciplines, interviews with others who had close interactions with the resident, and previous observations of the behaviors identified in E0200 for the 7-day look-back period. Our last few items in this section will provide more specific behaviors that may require a higher level of attention and care planning. In this subset, we will be documenting both the presence and frequency, starting with E0800, rejection of care. Review the medical record, interview staff across all shifts and disciplines, as well as others who had close interactions with the resident during the 7-day look-back period. If a decline or rejection of care is noted, determine if this is based on the resident's values, preferences, or goals for health care and well-being by confirming with the resident or their family. If so, then this would not be identified as a rejection of care. If a decline or rejection of care does not align with the resident's preferences or personal health care goals, then proceed with documenting the frequency of which this had occurred. Following will be item E0900, wandering. Wandering is the act of moving from place to place and can be with or without a specified course or purpose. Further, wandering may or may not be driven by confusion and is not always aimless. Review the medical record and interview staff to determine whether wandering occurred during the 7-day look-back period. If wandering occurred, determine the frequency of the wandering during the 7-day look-back period. Lastly, our section concludes with item E1100, change in behavior or other symptoms. Here we will review responses provided to items E0100 through E1000 on the current MDS assessment and compare it with responses provided on the prior MDS assessment. Taking all of these MDS items into consideration, you will make a global assessment of the change in behavior from the last MDS to the current MDS, and rate the overall behavior as same, improved, or worse. For residents with multiple behavioral symptoms, it is possible that different behaviors will vary in different directions over time. That is, one behavior may improve while another worsens or remains the same. Using clinical judgment, this item should be rated to reflect the overall direction of behavior change, estimating the net effects of multiple behaviors. Now that we've covered the fundamentals, let's review some popular coding tips directly from the RAI. Number 1. Delusions. If a resident expresses a false belief but easily accepts a reasonable alternative explanation, do not code it as a delusion. If the resident continues to insist that the belief is correct despite an explanation or direct evidence to the contrary, code as a delusion. Number 2. E200 behavioral symptoms should be coded based on whether the symptoms occurred and not based on an interpretation. Code as present, even if staff have become used to the behavior or view it as typical or tolerable. Number 3. Remember that when coding behavioral impacts on the resident or others, this item also represents risk, meaning actual harm does not need to occur in order to be appropriate for coding. If the risk itself is significant, then proceed with coding. Section E plays a pivotal role identifying the resident's needs, monitoring for changes, and developing a plan of care that addresses potential underlying conditions and safeguards the resident and others, which is why coding accuracy is imperative. For more information about coding the MDS, or to see more MDS-related content, follow our channel at MDS Made Easy. Brought to you by the Data Nurse, your partners in MDS Precision.